When we talk about CNS infections, there are a couple of facts that we need to understand. One, in spite of best of the antibiotics available today, incidence of CNS infections is increasing. Majority of these infections are treatable, and imaging plays a very vital role, basically because if you can detect and accurately diagnose these conditions, they are completely curable and patient can be completely well. Even before you look at imaging of CNS infections, two things we must understand. There are specific techniques of imaging, and the second thing is whether the patient is immunocompetent or immunocompromised is what you should know. So in next 15 minutes or so, we'll look at CNS tuberculosis, CNS cysticercosis, encephalitis, abscesses, post-infectious demyelination. Post-infectious demyelination is actually not an infection, but it is an infection-induced condition and it simulates clinically CNS infections. Hence, we'll see how we differentiate this from other conditions. Infections in immunocompromised patients we are not going to cover today, so these are excluded. Brief about technique of CNS infections. Contrast study is a must whether you are doing CT or MR. When you are doing CT, it should be double dose and you require a delayed acquired set of images. When you are doing MR, in addition to the standard T1, T2 flare and diffusion images, we require contrast, we require delayed images, and we also require MR spectroscopy to characterize these lesions better. We'll start off with CNS tuberculosis. We'll look at its pathophysiology, typical versus atypical imaging findings, sequelae and complications of CNS tuberculosis, and natural course of healed tuberculosis and MDR-TB. Cranial tuberculosis is broadly divided into parenchymal, meningeal, which is further divided into pachymeningeal and leptomeningeal, intraventricular tuberculosis, subdural tuberculosis, and extradural tuberculosis. Of all these, leptomeningeal tuberculosis is by far the commonest. It happens due to spread of these bacilli from blood stain. So, bacillemia gives rise to spread of this infection to the brain parenchyma. The bacilli get lodged in a small subpial or subependymal focus of infection, which is called as Reach's focus, which is similar to Ghon's focus in the lungs. Rupture of this focus contaminates subarachnoid spaces and CSF, and that leads to spread of this infection along CNS pathways, CSF pathways, which leads to leptomeningitis. And this is how leptomeningitis looks on MRI. On T2, you may get mild hydrocephalus. On post-contrast fat-sat T1 weighted images, you will see exudates across frontal parietal occipital convexities, some amount of exudates in the basal cisterns like you see here in the suprasellar cistern, interpeduncular cistern. You have enhancement along the folia of cerebellum as well. But this is not how common leptomeningitis in tuberculosis looks. This is the classic picture where you have focal exudates in the left MCS cistern, suprasellar cistern, and this particular patient, because of vasculitis, also has a small acute infarct in the left globus pallidus. So, this is how CNS leptomeningeal tuberculosis looks. Tuberculoma, on the other hand, is relatively less common presentation of CNS tuberculosis compared to leptomeningitis. It is usually secondary to an infective focus elsewhere in the body. It may or may not be associated with tubercular meningitis. So, typical tuberculoma would look dark on T2. It will be surrounded by mild to moderate degree of vasogenic edema. On T1, it is isointense to grey matter. Sometimes it is slightly hyperintense at the periphery. If you give contrast to these patients, the lesions will show thick ring enhancement, and it is usually seen as an area of thick ring enhancing lesion. Remember this because we need to differentiate this from cysticercosis. In pathology books is described completely differently. So, it begins as an area of tubercular cerebritis that eventually joins to form a mature non-caseating tubercular granuloma. It appears as a focus of high signal intensity on T2, which may not show any contrast enhancement, and hence differential diagnosis for this condition would be post-ictal edema, infarct, or even a low-grade glioma, and this is how a non-caseating tubercular cerebritis would look. More classically, you will see enhancing lesions which could be solid enhancing like this. They could be single or multiple. They could be nodular, irregular or A-plaque. And then differential diagnosis would be a tiny granuloma, which could be cysticercosis or sarcoid. It could be a small glioma, or it could be a tiny metastasis. More classically, you will see them as larger ring enhancing lesions with central non-enhancing area, which indicates necrosis. The wall and granulomatous part of tuberculoma would show contrast uptake, and hence the ring enhancing appearance. Differential diagnosis at this stage of this type of tuberculoma would be cysticercosis, abscess or metastasis. If you do not have an answer on routine imaging, MR spectroscopy can be quite useful. MR spectroscopy performed through the lesion would show a large lipid lactate peak extending from 0.9 to 1.2 ppm. All the other metabolites would be virtually absent. So, this is classically seen in majority of the granulomas, more commonly in tuberculomas. We will very briefly look at the other manifestations of CNS tuberculosis. The classic one is giant tuberculoma, which gives rise to onion peel like appearance. By definition, they should be more than 2.5 centimeters in diameter. They do not show restricted diffusion and show a large lipid lactate peak. This is another child with 5-year-old suspected to have pituitary mass, has a large cellular supracellular lesion which is dark on T2, and after giving contrast there is conglomerate ring enhancement. Spectroscopy again is showing a tall lipid lactate peak from 0.9 to 1.2 ppm. On the other hand, in children, although these tuberculomas are large, they are more commonly associated with vasculitis or moyamoya-like phenomenon, and this is an example of a 3-year-old child with a large giant tuberculoma in the left thalamus causing obstructive hydrocephalus. Also, this patient had leptomeningitis and enhancing infarcts in the anterior and posterior watershed zones. So, this is TBM with giant tuberculoma with multiple acute, subacute infarcts because of vasculitis caused by CNS tuberculosis. Again, in children, you will see disseminated tuberculomas as a part of tuberculosis in the chest, typically miliary tuberculosis. So, these lesions in the brain in patients suffering from miliary tuberculosis are smaller, they are less than 5 millimeters in diameter. Unlike larger tuberculomas which are dark on T2, this could be bright on T2. They show rounded enhancement, not ring enhancement, and they respond very well to conventional anti-TB line of treatment. Sometimes they can become chronic and become calcific and may have starry night appearance of what you see in cysticercosis. So, this is a case of miliary tuberculosis, 6-year-old child with miliary tuberculosis in the chest and has multiple tuberculomas in the brain which are showing thin and thick ring enhancement. Also note there is leptomeningitis in the right sylvian fissure.